Thank you. It's lovely to be here. I've never been to Turkey before, and I've really enjoyed the very short time that I've had to see a little bit of Istanbul so far. So thanks very much to the conference organisers for the invitation. I'm very aware that we are short on time. I don't know if there's many in the audience that know Australians are renowned for speaking very quickly, which I will be tempted to do, but I'll try not to talk too fast for the translator's sake. What I'm going to be talking about this afternoon are the findings of a study of which I was a small part, called the Global Burden of Disease Study. And I was involved with a group of people who oversaw the work to try and estimate the global burden of disease attributable to illicit drug use and dependence. So just to give you a bit of background, the Global Burden of Disease framework was initiated by the World Bank 2 decades ago, back in 1993. And the reason it was developed was because up until that time, when people had been trying to compare across different causes of health loss, people focused only on mortality. But there was a recognition that many health conditions cause disability that may not lead to someone dying, but nonetheless that person is living in less than perfect health. So the Global Burden of Disease, or GBD framework, uses information that combines what we know about conditions that cause loss of life and conditions that cause loss of well-being together, and allows it to compare across conditions to see where the burden lies. So before this was done, diseases like cancers really sort of were the focus of many people's attention. Obviously, illnesses such as HIV/AIDS, but mental and substance use disorders, although some of them do cause early mortality, really didn't rank very highly because many of them cause disability but not necessarily early death. So just to give you a background on how this measurement works, what GBD does is it combines health loss due to premature mortality, so that's years of life lost, or YLLs, along with years of life lived with disability, which is health loss because you're living a less than full life because you've got a condition that is leading you to be suffering in some way. Those two measures are added together to what's called disability-adjusted life years, which is a sum of the years of life lost because of early mortality and years of life lost because of disability. So that is called DALYs. Sorry, all right. So previous studies, so the GBD has been conducted before, but the earlier exercises did not really look at illicit drugs in much detail. They also didn't look at many of the risks of illicit drug use. So here I've just summarised a bit about the measures that are used in burden of disease, but I'll go through some of the methods that the study used. I'll also give an overview of what's called a comparative risk assessment, and that's essentially where you look at risk factors, in this case illicit drug use being a risk factor, for other health outcomes. I'll summarise the estimates that we generated after we did our work of the number of people who we think were dependent upon 4 major drug types. Summarise what we found in terms of years of life lived with disability, years of life lost, and then the summary measure, which is DALYs. And then summarise what we were able to estimate in terms of the burden due to illicit drug use as a risk factor for other health outcomes. Ah, is that working? I think I'm pedalling wrong. What am I doing? I'm pressing that one, it's not working, okay. So to give you an overview of the disorders we considered. So in the previous GBD, essentially there was a summary of opioids, which was heroin, cocaine and amphetamines. It was all grouped together in one combined estimate. Cannabis use was not considered, other drugs were not considered. In the 2010 study, we looked at all 4 of those major drug types separately. So separately for opioids, which was essentially heroin, cocaine, amphetamines and cannabis, and some consideration of other drugs. I'm left-handed, so I'm obviously at a disadvantage. So to summarise the methods, anyway, bear with me. So essentially what the Global Burden of Disease study is, it uses existing data. So we didn't collect new data, but what we did was we searched as far and wide as we could to find all of the epidemiological data on the prevalence of drug dependence, the incidence of drug dependence, what were the risks of mortality, and how long does drug dependence last if you become dependent. We looked across the whole world for estimates in all countries. We then used those data points to model what we could, from that data, what we think the epidemiology of drug dependence looks like. We then estimated the burden for each drug use disorder. And then we looked at what's called attributable burden. So this was for 3 major exposures: opioid, cocaine and amphetamine dependence as risk factors for suicide, cannabis as a risk factor for schizophrenia, and injecting drug use as a risk factor for HIV, hepatitis B and hepatitis C. I'll go into why we focused on those later in the talk. We also compared estimates for 1990 and 2010. So compared to previous exercises, and this refers to the whole study, not just the work that we were involved in, what GBD 2010 did that was different from earlier iterations was the extent of the systematic reviews of the existing evidence on the epidemiology of disorders. We also looked at uncertainty, so recognising that there are a lot of gaps in what we know, we then modelled uncertainty around the estimates to be clear about the fact that there are a lot of things that remain unknown. It used a new software program that had been developed. There were new risk assessments undertaken. And one of the core things that the Global Burden of Disease uses is what's called a disability weight, which is how estimates are generated to come up with estimates of years of life lived with disability. The other thing that was an increase in terms of the involvement of outside people was the core team, which was led by a consortium led by at the University of Washington in Seattle, but also involving WHO and a number of other universities, was they convened expert groups. We were the illicit drug use expert group, but they did that across all diseases and injuries. I won't go into the modelling in too much detail, mainly because I didn't do it, so please don't ask me any detailed questions later. But just to assure you, it was designed by people who know a great deal about mathematical modelling. The data that we located in our systematic reviews was used in what's called with a Bayesian approach. And essentially what it meant was it used all the different pieces of information on prevalence, incidence, mortality risk to come up with a model that was internally consistent about what the epidemiological model of drug dependence or any other disorder. So this is to give you an idea of what we found, but also the major gaps that exist in the data. I don't know how easy it is for you to see those estimates, but the text there refers to each of the regions that the Global Burden of Disease study comprised. At most, there are 4 groups of numbers. So if I look at North Africa and the Middle East, you'll see that there's 3 different numbers. There's a CA with a 9, a CO with a 6, and an AM with a 3. What that means is we could find 9 estimates about the epidemiology of cannabis use or dependence, 6 for cocaine use or dependence, and 3 for amphetamine use or dependence. We couldn't find any population estimates of the prevalence of opioid dependence or mortality among opioid-dependent people in this region. So just to give you an idea of how limited the data are in many regions of the world, just focusing on the region we're in at the moment. So there was a lot of variation across regions. So the most amount of data was in North Africa and Western Europe. And there was also variation across drugs. So there were a lot of estimates of cannabis use, for example, a lot of estimates of opioid mortality. So what that means is essentially there is a lot that we do not know, which means that the mathematical modelling imputes a lot more information. So this is to give you an idea of the estimates that we generated. This is at a global level of the number of people who we estimated who were dependent by drug type and also by sex in 2010. The first thing to note is more males were estimated to be more males who were dependent on all drugs than females. That's pretty consistent with what we know from the literature. The second is that opioid dependence and amphetamine dependence globally were estimated to be the most common types of drug dependence, whereas cocaine dependence was the least common. So if you look at the purple bar, that's for opioids. So about 10.5 million men were estimated to be opioid dependent, and just over 4 million women opioid dependent around the globe in 2010. This is just to give a bit of context for how mental and substance use disorders compare to other conditions. I don't know if is there a pointer? Yeah. I'll just use my hand. If you look at the red row and the middle column is looking at the proportion of total disability, so people living in less than perfect health. Mental and substance use disorders were the biggest cause of disability in the world of any of the groups of conditions. So they caused almost 1/4 of all disability across the globe in 2010. When you look at premature mortality, it was cardiovascular and other circulatory diseases that were the biggest causes. So this is just looking at how substance use disorders compare to other mental disorders. So the green wedges are substance use disorders, and you'll see that illicit drugs were responsible for almost half of the estimated years of life lost due to all mental and substance use disorders. Now these are the disability adjusted life years. So this is when you add together years of life lost, years of life lived with disability, and you can see that opioid dependence is by far the biggest cause of disability in the world, burden of disease of the 4 drug groups. And it was responsible for over 9 million disability adjusted life years, or DALYs, in 2010. And of those, there were many more that were due to early mortality compared to disability. And if you look at how it looks over the age span, so the blue bars are males and the green bars are females, the burden was much bigger among men, and it was much bigger among young adults. So none of this should really be surprising, because what it is doing is telling us what we should know from existing data, but that is definitely what the modelling suggested. So the biggest age ranges for burden are between the ages of 20 and 29 years for both sexes. So I mentioned that we would talk about this. I would mention how we looked at the health risks of illicit drug use. So we didn't just look at whether or not something was associated. So many things are more common among people who use drugs. What we needed to do was to rule out other explanations for why these two things might be associated. So we had to look at whether or not we thought there could possibly be a causal relationship between drug use and the outcome. And that's why only the three major groups of exposures and outcomes were ultimately selected. It's pretty commonly accepted injecting drug use as a risk factor for HIV and hepatitis. Similarly, drug dependence as risk factors for suicide. And for cannabis use, what we looked at, we didn't look at cannabis as a cause of schizophrenia that would not otherwise have occurred. But cannabis use as a risk factor in terms of bringing the disorder on among people who would otherwise develop the disorder anyhow. And for those who had already developed schizophrenia, that they spent a greater time in being more unwell. We looked at a lot of different outcomes, but we could not, they did not meet the level of evidence that we needed to include them, and that included injuries, homicide, cancers, road traffic accidents, cardiovascular disease, stroke, many outcomes that many people talk about as risks of illicit drug use. The quality of the evidence on those associations was not considered high enough by the study more broadly, not just us, for them to be included. And when you look at how these risk factors compare, the biggest cause of burden was injecting drug use as a risk factor for HIV. That was by far the biggest burden of all of the risks of drug use that we included, followed by suicide as a risk of drug dependence. So to summarise the total, so when you look at drug dependence as a cause of burden in itself, along with drug use as a risk factor for other health outcomes, this is what it looks like. So essentially, once the red colours indicate a higher rate of burden, the blue colours indicate a lower rate of burden per 100,000 population. And essentially, the countries where it was highest were countries that include my country, Australia, as well as the Russian Federation, the United States, and England. And you'll see there in the middle the blue and the green and the yellow colours indicate those around the middle. If we look at how that varies statistically, so the orange colours mean that it's significantly higher than the global average. You can see there all the countries that we found where the rate of disease burden due to illicit drug use was higher than the global average. Now, in terms of putting it in perspective, illicit drugs were estimated to cause 1% of all disease burden in the world, and it was the 8th largest contributor to disability among males. And that's about a quarter the size of alcohol burden. Alcohol obviously is a significant cause of disease burden, but when you consider how much less prevalent illicit drug dependence is, there's obviously a lot more burden per person who is dependent. So just some brief discussion points. So this is the first estimates that have been made of specific types of drug dependence at a global level, but we also estimated prevalence at a country level. Those estimates were modelled, so there's a lot of uncertainty around those estimates. Opioid dependence was the biggest cause of burden globally. Injecting drug use was the biggest contributor as drug use as a risk for other health outcomes, mostly because of HIV and also because of hepatitis C. What I didn't emphasise in the slides is cannabis use as a risk factor for schizophrenia was estimated to cause very little burden, essentially because people with schizophrenia already were experiencing a lot of burden. Obviously, the illicit nature of these drugs has not prevented people from continuing to use them, from being dependent on them, and from them to cause them a significant disability. So there's a clear need to tackle a number of issues, particularly overdose, suicide, to increase the coverage of preventions that we know work, evidence-based interventions particularly for opioid dependence, which we know are effective in reducing opioid use, in reducing opioid mortality, and that particularly includes opioid substitution therapy such as methadone and buprenorphine, as well as needle and syringe programs, and for those people who are HIV positive, antiretroviral therapy. And there's also a need to scale up treatment not just for HIV but also for hepatitis C. And there's also a need to investigate new and better interventions for other kinds of drug dependence. There are a lot of gaps which are really, that was one of the major things that we really wanted everyone to be clear about. There are many countries do not know how many people use drugs, let alone how many are dependent on them. So one of the things that we really hope come out of having done these reviews is that people understand better what we don't know. The gaps were greater, greater in low and middle income countries. There are a lot of gaps, particularly in incidence and in mortality, and there's a lot we need to investigate better in terms of the consequences of illicit drug use. So I'll finish there. I was trying to speak slowly, sorry if I went over time. But just to acknowledge there was a very large number of people who worked on this study. So I'd like to acknowledge those, to the expert group, and particularly to the people who helped with all of the reviews of evidence. Thank you.